Hello friends, welcome to my channel. Myself Anisha B. Nair, MBBS student of GMC Trivandrum. Today we will go through the following session. Objective of my class is, after the end of my presentation, you will be thorough with modes of transport and the terminologies tubular maximum, renal threshold and reabsorption of some solutes such as sodium, potassium, chloride, glucose and water, and about secretion. For the substance to be transported, it must first be transported across the tubular epithelial membrane to the renal interstitial fluid, then through the peritubular capillary membrane back into the blood. We have two modes of transport, active and passive, and the transport can be transcellular or paracellular. So, what are the modes of transport? Under passive, solvent drag, osmosis, passive diffusion, and facilitated diffusion. And under active transport, there are primary and secondary transport. So, what is meant by transcellular? The transport through the membrane, and paracellular means between the cell junction. It is clear from this diagram. So, what is diffusion? Diffusion means from higher concentration to lower concentration, and it is along the concentration gradient. Example, glucose and certain ions. Facilitated diffusion means a specific carrier protein. Example, reabsorption of glucose via GLUT. And coupled transport is also coming under this. Coupled transport are of symport and antiport. Symport means two or more solute in same direction. Example, sodium amino acid and sodium glucose transport. What is antiport? Two or more solute in opposite direction. Example, sodium hydrogen exchange. Then about solvent drag. When bulk amount of water is reabsorbed, solute dissolved in water also transported. Example, potassium and calcium. And then about osmosis. When considerable amount of osmotically active solute is transported, water is reabsorbed along with it to maintain osmotic balance. This is the major mechanism for reabsorption of water from tubular lumen. Just recall where you get glycosuria in diabetes mellitus, which producing osmotic diuresis due to holding of water by glucose molecule. Here in this diagram, in active transport, which obtain energy directly from ATP, and in secondary active transport, which obtain energy indirectly from ATP. Example for primary active transport include sodium potassium ATPase, hydrogen ATPase, hydrogen potassium ATPase, and calcium ATPase. And some examples for secondary active transport, sodium glucose co-transporter, sodium amino acid co-transporter, sodium inorganic phosphate co-transporter, sodium hydrogen exchange, and sodium lactate co-transporter. So next we can go through reabsorption. As the glomerular filtrate enter the renal tubule, it flows sequentially through successive parts of the tubule, the proximal convoluted tubule, the loop of Henle, the distal collecting tubule, the collecting tubule, and finally collecting duct before it is excreted as urine. Along this course, some substances are selectively reabsorbed from the tubule back to the blood, whereas others are secreted from blood to the tubular lumen. So eventually, urine that is formed represent some of the three basis renal process, that is glomerular filtration, tubular reabsorption, tubular secretion, that we discussed in the previous video. Now in this class, we will discuss about tubular functions mainly. So it is clear from this diagram that in each part of the tubule, what all are the substances absorbed and secreted. In PCT, water is 65% absorbed and sodium 67%, potassium 65% and glucose and amino acid 100% it is reabsorbed and chloride ion 55 to 60% and HCO3 80 to 90% and urea 50% and secretion H plus, NH4, urea, creatinine which is variable. At the end of the PCT, the tubular fluid is isotonic. And in loop of Henle, reabsorption, water 15%, sodium 25%, potassium 25 to 30%, chloride and 35%, and secretion, urea, creatinine, variable. At the end of the loop of Henle, tubular fluid is hypotonic. And distal convoluted tubule, the reabsorption, water is only 5% and sodium 5% and chloride ion also 5%. So at the end of the DCT, the fluid is hypotonic. Last part, that is collecting duct, reabsorption, water 15%, sodium 3%, urea variable, secretion potassium, hydrogen, urea which is variable. Tubular fluid coming out of the collecting duct is normally hypertonic. So for the substance to be reabsorbed, it must first be transported across the tubular epithelial membrane into the renal interstitial fluid. Then through the peritubular capillary membrane back into the blood. So here you can see the proximal convoluted tubule. So this is the most important part of the nephron as it absorbs 67% of the filtered water, potassium, sodium, chloride, HCO3 and almost all the filtered glucose and amino acid. It is clear from the diagram 70% of the PCT is convoluted and remaining straight. Functionally, both parts are similar. So, primary focus of reabsorption process in the proximal tubule is directed at the sodium reabsorption, which is usually secondary to electrochemical gradient created by sodium potassium pump located on the basolateral membrane of the epithelial cells. Reabsorption of water and most of the solute is directly or indirectly linked with sodium potassium pump. Therefore, abnormality of this pump result in many renal dysfunction. So, sodium potassium ATPase pump is very important. Whenever you think of the proximal convoluted tubule, remember these points. First point, fluid in the early part of the proximal convoluted tubule is almost isotonic to plasma. In filtrate, sodium and the two major cation, chloride and HCO3 are the major solute, of which HCO3 reabsorbed mainly in the convoluted portion of the proximal tubule, leading to drastic fall in the rest of the tubule. Chloride is reabsorbed in the second half of the proximal tubule. So look at the diagram. About 67% of the filtered potassium reabsorbed along with the 67% of the water, and glucose and amino acid are almost completely absorbed. Thus, at the end of the proximal tubule, only 1/3 of the sodium, 1/3 of the chloride and 1/3 of the potassium and HCO3 only 20% remain with the absence of glucose and amino acid. However, urea concentration is increased as it is not at all absorbed in the part of the tubule. Next we can see how the glucose reabsorption occurs. Glucose reabsorption, we have SGLT2 and SGLT1 on brush border of the proximal tubular cells. 90% of the glucose absorption by SGLT2 present in the early segment, 10% by SGLT2 in late segment. On basolateral side, glucose diffuse out of the cell into the interstitial space by GLUT2 in S1 segment and GLUT1 in later segment. This is an example for secondary active transport where glucose absorbed with the help of sodium potassium ATPase indirectly. So look at the diagram. Here SGLT2 present in the apical membrane and GLUT2 transported present in the basolateral membrane which transport glucose to the interstitial fluid. And on the basolateral membrane, here you can see the sodium potassium ATPase pump. Then the terminology, what is meant by tubular maximum? So we will try to understand about what is tubular maximum or transport maximum. Remember, glucose is 100% reabsorbed along with amino acid in PCT. These are examples of secondary active transport. For most substances that are actively reabsorbed or secreted, there is a limit at which solute can be transported. This is referred to as transport maximum. And this limit is due to saturation of the specific transport system involved when amount of solute delivered to solute exceed the capacity of the carrier protein and specific enzyme. Glucose transport system is very good example for this. Normally you don't see glucose in urine because all are absorbed in the proximal convoluted tubule. But when filtered load exceeds the capacity, it can appear in urine. In adult human, transport maximum of glucose is 375 mg per minute, whereas filtered load of glucose is only 125 mg per minute. How did you get that? It is the glomerular filtration rate into plasma glucose. That is 125 ml per minute into 100 mg per 100 ml. You get 125 mg per minute. This shows the relationship between filtered load, plasma concentration, tubular maximum, rate of glucose in urine. Look at the diagram. Here you can see when plasma glucose is 100 ml per minute, there is no glucose in urine. However, when plasma glucose reaches 200 mg per 100 ml, that is filtered glucose 250 mg per minute. At this point, you have glucose in urine. Note that this threshold occurs well below the transport maximum. This is another graph showing the same phenomenon. It is very clear from this diagram. When the graph of the TMG is plotted, the actual curve deviates from the ideal curve. This deviation is called a renal splay. And the splay is due to two reasons. First reason, the TMG is not same in all the tubule. Second reason, amount of glucose removed from each tubule is not complete even when the amount filtered is below the TMG. So here the TMG is approached somewhat gradually along a curve rather than abruptly with a sharp deflection. Next is about sodium reabsorption. So look at the diagram. Sodium potassium ATP is present in the basolateral membrane of the tubular epithelial cells. So it hydrolyzes the ATP and uses this energy to transport sodium out of the cell into the interstitium. At the same time, potassium enters the cell. So now we have a low intracellular sodium and high intracellular potassium, and this creates net negative charge of about minus 70 millivolt within the cells. After understanding this physiology, now we know that low sodium from tubular fluid enter freely through the passive diffusion because of two reasons. There is an ion gradient favoring the sodium diffusion as intracellular sodium is low 12 milliequivalent per liter and tubular fluid sodium high 140 milliequivalent per liter. Second reason, the negative intracellular potential attracts the positive sodium ion from the tubular lumen into the cell. So in short, sodium absorption favored by first one, sodium potassium ATPase in most part of the tubule. Second, extensive brush border on the luminal side of the membrane that increase the absorption to 20-fold by carrier protein through facilitated diffusion. And fourth reason, through the secondary active transport, which is important to transport other substances such as glucose and amino acid. So it is very clear from the diagram, sodium potassium ATPase, which is present on the basolateral membrane and which reabsorb sodium to the interstitial fluid, and the potassium is infused into the cell. And the second one, there is a sodium solute co-transporter present, and third one, there is a sodium hydrogen antiport is present. 60% of the total sodium entry through this transport, and that is the primary mechanism. And the fourth one, that is associated anion reabsorption. So in the PCT, in the first half, sodium reabsorbed along with HCO3, and in second half, sodium reabsorbed along with the chloride ion. So sodium and HCO3 reabsorption is coupled to transport of organic solutes such as glucose amino acid. So that create an osmotic gradient which favor the water reabsorption. So sodium reabsorption, 67% PCT mainly by a sodium hydrogen exchanger, 25% thick loop of Henle via sodium potassium chloride transport, and 5% DCT via sodium chloride transport, and 3% collecting duct via ENaC channel. Next, we can discuss about chloride reabsorption. So chloride reabsorption, here we can see that it is occur through the chloride anion exchanger and also chloride passively passing through the proximal convoluted tubule. And in thick ascending limb, along the apical membrane there is sodium chloride potassium transporter, and on the basolateral membrane there is a Bartin channel, and in thin ascending limb there is Bartin channel present on apical membrane and basolateral membrane. So in summary, in second half of the PCT, sodium reabsorption mainly associated with the chloride reabsorption via transcellular and paracellular. Why the chloride absorption occur in later part in the PCT? This is because chloride ion concentration is very high, and also the presence of chloride anion antiport. And the water moves out of the tubule secondary to sodium reabsorption. Because of that, luminal chloride is increased and chloride ion is passively absorbed along the electrochemical gradient. In the PCT, there is leaky channels and 25% of the sodium chloride absorbed in PCT. And it is clear from this diagram that is sodium potassium ATPase present on the basolateral membrane, and the chloride ion is reabsorbed in the thick ascending limb of loop of Henle via sodium chloride potassium symporter located in the apical membrane. So remember, sodium pumped out by sodium potassium ATPase, chloride can leave the cell by potassium chloride symporter. And in the DCT, there is sodium chloride transporter present on the apical membrane and CLC-KB channel present on the basolateral membrane. And of course, the sodium potassium ATPase pump also present on the basolateral membrane. This is two clinical scenarios. What is meant by Barter's syndrome? Mutation of the sodium chloride potassium channel in the thick ascending loop of Henle, which can present as congenital anomaly. And Gittelman syndrome, there is mutation of NaCl symport in DCT. This is also a clinical scenario how the loop diuretics act. So the loop diuretics action is on sodium potassium chloride transporter in the loop of Henle. So here the lupodiuretics that cause loss of sodium and water, hypokalemic metabolic alkalosis and increased calcium loss. And thiazide-diuretics, its site of action on the distal convoluted tubule. So thiazide-diuretics that act on the sodium chloride symport, and its main action loss of sodium and water, and it causes hypokalemic metabolic alkalosis and increased calcium reabsorption occur. Next is about water reabsorption. Water reabsorption, we all know that there is obligatory and facultative water reabsorption, and 65% water reabsorption occur in the PCT. And what is the driving force? Transcellular osmotic gradient. That is the sodium which is reabsorbed along the apical membrane to the interstitial fluid, and ultimately that will create high osmolality in the interstitial fluid. And it can be transported through the tight junctions and also through the aquaporin 1 on the apical membrane, and coupled with reabsorption of solute sodium chloride and bulk flow, that is by means of solvent drag along with the potassium and calcium. And ultimately the interstitial fluid have a high hydrostatic pressure that also favor the water reabsorption to the peritubular capillary. So we all know that peritubular capillary is the direct extension of the efferent arteriole, and efferent arteriole is rich with protein. So there is high oncotic pressure and low hydrostatic pressure. So that also favor the water reabsorption. Then the loop of Henle. The thin descending limb is permeable to water and not to solute, but the thin ascending and thick ascending water impermeable. So water permeability decreases towards the down and water content increases, but solute is reabsorbed in the thick ascending limb. So what happened? Isotonic condition become changed to hypotonic, and 15% in the distal descending loop of Henle. Next is the DCT. DCT is essentially the extension of thick ascending limb of Henle, and it is water impermeable in spite of osmotic gradient. Sodium chloride absorption via sodium chloride imported occur here. So what happened here? Here the urine is more dilute. Here in DCT, water absorption is 5% and 15% in the collecting duct. This is a diagram which shows there is sodium chloride imported in the apical membrane, and chloride channel and potassium channel, and sodium potassium ATPase on the basolateral membrane. Then how the water reabsorption occur in cortical part and medullary part. So cortical part, it is 15% occur, and this is via the action of ADH. So ADH act on V2 receptor, and that convert ATP to cyclic AMP, and cyclic AMP it act via two modes. First one, it activate protein kinase A and increase the vesicles with aquaporin 2, and also it act on the nucleus and gene transcription occur and increase the aquaporin 2. And in medullary part there is 5% occur. So here the osmolarity of the interstitium very high, and this part also play a role in countercurrent mechanism. So what is the role of ADH in cortical part? If ADH present, urine osmolarity even reach up to 1400. If ADH absent, urine hypotonic and osmolality 30 milliosmol per kg. So, collecting duct is not totally impermeable. Even 2% can be absorbed in the absence of ADH. Next is about HCO3 reabsorption. 90% of bicarbonate is reabsorbed into the PCT by secondary active antipode via sodium hydrogen exchanger. Bicarbonate alone cannot maintain normal acid balance. Therefore, kidney is capable of generating new HCO3 as well. HCO3 reabsorption throughout occur except descending limb of loop of Henle. In PCT, HCO3 reabsorption is 90% via sodium hydrogen exchanger. In DCT and CT, it is 10% via hydrogen potassium ATPase. So here it is clear from the diagram. In PCT cell, there is on the apical membrane there is sodium hydrogen exchanger and hydrogen pump, and the filtered HCO3 reacted with the secreted H plus to form H2CO3, and with the help of carbonic anhydrase it dissociate and H2O CO2 enter the cell, and new HCO3 formed inside the PCT cell, which is transported and reabsorbed into peritubular capillary along the secondary active transport. For each mole of HCO3 removed from the tubular fluid, 1 mole of HCO3 diffuses from tubular cells into the blood, even though it is not the same mole that disappeared from tubular fluid. So the buffering of secreted H plus by filtered HCO3 does not contribute to urinary excretion of H plus. The carbon dioxide formed in the lumen from secreted H plus returned to tubular cell to form another H plus, and therefore no net H plus secretion occur. And in DCT cell, there is hydrogen pump and hydrogen potassium ATPase pump in the apical membrane, and here also no HCO3 formed, and that is reabsorbed into the peritubular capillary. So how the potassium reabsorption and secretion occur? Potassium is the only solute which is reabsorbed and secreted. Only 2% of potassium in the extracellular fluid. 60% absorbed in the PCT. 20% in the thick ascending limb. K plus reabsorption occur by active transport in the PCT, ascending limb of loop of Henle, DCT, collecting duct. K plus secretion involve active and passive process. So the critical step is active transport of potassium from interstitial fluid across the basolateral membrane by the sodium potassium ATPase. This creates an elevated intracellular potassium which favor passive transport of potassium to lumen. So what are the factors affecting potassium transport? Tubular secretion of potassium is markedly decreased in potassium and sodium depletion. In DCT, potassium and hydrogen are both exchanged for sodium, which is reabsorbed, and the two ions compete for the exchange mechanism. Therefore, potassium excretion is decreased when H plus secretion is increased. Aldosterone also increases the potassium secretion. Alkalosis, insulin, aldosterone, catecholamines shift the potassium into the cells. But in diabetes mellitus, due to insulin deficiency, Addison's disease, tissue damage, which shift the potassium out of cells. So how the potassium transport in loop of Henle? There is sodium potassium chloride transported and potassium ROMK channel is there. What is ROMK channel? The renal outer medullary potassium channel is an ATP dependent potassium channel that transport potassium out of the cells. It plays an important role in potassium recycling in thick ascending limb and potassium secretion in cortical collecting duct of the nephron. In humans, ROMK is encoded by KCNJ1. And principal cells of cortical collecting duct, apical membrane, there is ROMK channel which help in the potassium secretion and ENaC channel which absorb the sodium. And the RONK channels are inhibited by magnesium in nephron in normal physiologic state. So in states of hypokalemia, concurrent magnesium deficiency result in a state of hypokalemia that may be more difficult to correct with the potassium replacement alone. This may be directly due to decreased inhibition of the outward potassium current in state where magnesium is low. Conversely, magnesium deficiency alone not likely to cause a state of hypokalemia. High aldosterone level, increased sodium uptake, etc. may also be required to result in clinically significant renal potassium loss. Potassium sparing diuretics. Potassium sparing diuretics in the cortical collecting duct. Cells in this region of nephron absorb sodium via luminal membrane called the ENaC channel. Sodium influx across the luminal membrane leave lumen negative potential, which drive the reabsorption of chloride and efflux of potassium. Cytoplasmic sodium is transported across the basolateral cell membrane by the sodium-potassium ATPase. The collecting duct is the major site of action of mineralocorticoid receptor antagonist. Examples spironolactone, epilerinone, which decrease the expression of ENaC channel. And direct ENaC inhibitors, amiloride, triamterene, inhibit sodium influx through epithelial sodium channel in the luminal membrane. So it is very clear from this diagram there are ENaC blockers and aldosterone antagonist. ENaC blockers, there is reduced sodium influx that decreases the electrogenic exchange of sodium for potassium and hydrogen. So what happens? This can cause hyperkalemia and acidosis. Aldosterone antagonist, how it acts? Because of aldosterone antagonist, there is loss of sodium and water and hyperkalemia occur, and some risk for acidosis also present. So what is the role of collecting duct? So final osmolality, composition, volume of urine, which are determined by collecting duct. So most of the excreted potassium come from collecting duct by secretion. And the action of ADH that we already discussed. Here we have two type of cell, principal cells and intercalated cells. Principal cells reabsorb sodium and secrete potassium that help to maintain potassium metabolism, and it is facilitated by aldosterone via ENaC channel. So if you eat potassium more, you secrete more, and potassium excreted you reabsorb. Okay, and intercalated cells secrete H plus or HCO3 and role in acidification mainly, and it conserve potassium. Then what is the action of aldosterone? Aldosterone, it is prominently act on the nucleus and it synthesis SGK and other protein, and it act via ENaC and sodium potassium ATPase and increase the activity of ENaC and stimulate the activity of sodium potassium ATPase. So ENaC channel, here you can see it is present on the apical membrane and sodium potassium ATPase on the basolateral membrane. Then how the H plus secretion occur? This occur in the PCT, lack of PCT, DCT and collecting duct, and PCT sodium hydrogen antipode and 85% occur, and in DCT it is 10% and in collecting duct it is 5%. And what is the role of alpha intercalated during acidosis? There is aldosterone have an important role via two energetic mechanism and one non-energetic mechanism. Aldosterone having important role in the hydrogen secretion. So there are in the apical membrane, here you can see the hydrogen ATPase and hydrogen potassium pump and sodium hydrogen pump. And aldosterone have important role in this hydrogen secretion, and but in beta intercalated cells it increase the H plus. And here the new HCO3 formed which is reabsorbed into the secreted into the lumen. So friends, please like and subscribe my channel. Thank you all.